Chapter 24, endocrine disorders. So we start with the thyroid gland. So thyroiditis, inflammation of the thyroid gland. So it's a group of disorders. So we have various causes: infectious thyroiditis. Next, Hashimoto's chronic lymphocytic Hurtle cell painless thyroiditis. Next, de Quervain's subacute granulomatous painful thyroiditis. And then Riddle-Stoney had thyroiditis. Next, Hashimoto's thyroiditis. Remember it like this: Hashimoto. So add Hajinomoto to cutla fish for proper taste. So cutla fish. So CTLA4 polymorphism is there and proper taste. So PTPN22, PATPAN22. So Hashimoto's thyroiditis is a chronic lymphocytic thyroiditis. So there is chronic inflammation, lymphocytes are there. Autoimmune disease, so it is more common in women than in men, and it peaks between 45 to 65 years of age. Next, genetic factor. There is a strong genetic component which is supported by the disease in higher frequencies in monozygotic twins and presence of circulating antibodies in siblings, and also association with other autoimmune diseases. So genetic susceptibility, there are polymorphisms in genes associated with immune regulation of T cell responses, such as cutla4 and PTPN22. Next, pathogenesis. So first, it is an autoimmune disease. There is a breakdown in self-tolerance. It is characterized by presence of circulating autoantibodies against TPA enzyme, so thyroid peroxidase enzyme, and against thyroglobulin. So first what happens is there is a failure of self-tolerance caused by CTLA4 or PTPN22 gene polymorphisms. So all the then there is a failure of self-tolerance. So it could also be due to abnormalities in Tregs or T regulatory cells. Next, that leads to induction of thyroid autoimmunity, and then there is a progressive destruction of thyrocytes. So how does that happen? So T cell mediated responses are there, right? So first, type 4 hypersensitivity can happen, in which T cytotoxic killer cells, CD8 cells, they can directly attack the thyrocytes and kill them. Next, we can have CD4 helper T cells which release interferon gamma, thus activating macrophages, which again attack the thyrocytes. Okay. Next, we can finally have antibody dependent cell mediated cytotoxicity. So plasma cells produce antibodies against TP and thyroglobulin, and after these antibodies bind, NK cells, they bind to these antibodies, they recognize them, and they destroy the epithelial cells. Okay. So moving on to the morphology. So first we have to remember that the capsule is intact. Fibrosis does not spread beyond the capsule, whereas in Riedel's thyroiditis it spreads beyond the capsule. Capsule is intact. It is firm and nodular because you have immune complexes. So it is nodular, it is firm. There is a diffuse and symmetric enlargement of thyroid gland. The cut surface is pale grey tan, and it shows accentuation of the normal lobulation. So obviously there is a dense mononuclear inflammatory infiltrates with the lymphoplasmacytic infiltrate in the parenchyma, and you have lymphoid follicles with well developed germinal centers. Okay, and then there is atrophy of the thyroid follicles which appear smaller than the normal follicles, and there is Hurtle cell metaplasia. It is a metaplastic response of the follicular epithelium to injury. So Hurtle cells are Ashkenazi or oxyphil cells or oncocytes. They have abundant eosinophilic granular cytoplasm, prominent mitochondria also. Next, fibrosis. So the interstitial connective tissue is increased, and it may cause atrophy of the thyroid follicles, and it does not extend beyond the capsule of the gland. So FNAC shows Hurtle cells with a heterogeneous population of lymphocytes. So clinical cause, it is a painless enlargement of the thyroid in middle-aged woman, autoimmune. Hypothyroidism develops because of destruction of the thyroid cells, and early stages may produce transient thyrotoxicosis due to destruction of the thyroid follicles with secondary release of thyroid hormones. It is called Hashimototoxicosis. So Hashimoto's thyroiditis is the most common cause of hypothyroidism in regions with adequate iodine levels. And so here you can see, first you have lymphoplasmacytic infiltrate with well developed germinal centers, then interstitial fibrosis which does not extend beyond the capsule of the gland, and atrophic follicles with Hurtle cell change. Next, subacute granulomatous thyroiditis. It is called de Quervain's subacute viral painful granulomatous thyroiditis. It usually follows an upper respiratory tract infection. So granulomas are seen because multinucleated giant cells, they surround the escaped colloid. Why is the colloid escaping? Because viruses, they kind of eat the follicle, and you can remember it like that. So the colloid escapes, it elicits an inflammatory response. So it is less common than Hashimoto's disease. It affects women again and 40 to 50 years of age. So it is thought to be initiated by viral infection. So most of them, they have URTA before the onset of thyroiditis, seasonal variation in the summer, association with virus infections, so Coxsackie virus, mumps, measles, etc. So basically what happens is probably the viral infection exposes a viral or thyroid antigen which is released secondary to virus-induced host tissue damage, and this stimulates toxic T lymphocytes which damage the thyroid follicular cells. So there is unilateral or bilateral enlargement of the thyroid gland. It is firm and yellow-white. So again, damaged thyroid follicles, there is an escape of colloid, so that elicits an inflammation. So there are lymphocytes and macrophages and plasma cells. And then there's a granulomatous reaction, so multinucleate giant cells, they surround the pools or fragments of colloid. Hence there is granuloma formation, and again fibrosis develops at late stages. So there is painful enlargement of the thyroid, and early phase there is hyperthyroidism with high serum T4 and T3 levels and low serum TSH levels, and there is recovery within 6 to 8 weeks because it's a viral infection, it recovers, and thyroid function returns to normal. Next, Rydell's thyroiditis, it is a less common form, so etiology is not unknown, but usually they suggest an autoimmune etiology. The thyroid is stony hard and fixed, which clinically stimulates a thyroid carcinoma. There is extensive fibrosis that spreads beyond the capsule of the gland. So, thyrotoxicosis, it is defined as a systemic syndrome with hypermetabolic state caused by exposure to excessive levels of thyroid hormones, so free T3, T4. So, the causes, you have primary hyperthyroidism. So, there is excessive synthesis and excessive secretion of the thyroid hormone. So, primarily, it could be due to abnormal thyroid stimulation, as in diffuse hyperplasia seen in Graves' disease, or it could be because of any intrinsic disease of the thyroid gland, so toxic multinodular goiter or toxic adenoma of the thyroid. So, the trick is GTA trademark. So, GTA, so Graves, TA for toxic adenoma, and TM for toxic multinodular goiter. Secondary hyperthyroidism is because of a TSH secreting pituitary adenoma, which is rare and not associated with hyperthyroidism. You have decurvens thyroiditis, struma ovariae, and also factitious thyrotoxicosis, so exogenous thyroxine intake. It is factitious, it is false. So, clinical manifestations of hyperthyroidism, obviously there's a hypermetabolic state due to overactivity of the sympathetic system. Then there's an increase in BMR, the skin, there is heat intolerance, and it is soft, warm, and moist. Cardiac manifestations, obviously increased cardiac output, tachycardia, palpitations, arrhythmias, etc. There is fine tremor, there is hyperactivity, nervousness, and anxiety. Again, you can see Graves' ophthalmopathy, which is because Graves' disease is associated with proptosis, there is lid retraction, and again lid lagging also. And gastrointestinal system, there is increased stool frequency, often with diarrhea, hyperactivity of the GIT. And again, skeletal system, there is osteopenia, increase in fracture rate, small increase. Thyroid storm, it is a sudden onset of severe hypothyroidism, most commonly occurs in Graves' disease and probably due to sudden elevation in catecholamine levels. So, diagnosis, again, serum TSH concentration, single most useful screening test for hyperthyroidism because it is decreased even at subclinical stage. Free T4, it is increased. Measurement of radioactive iodine uptake is also used to determine the cause. For example, it is diffusely increased in Graves' disease. Solitary nodule takes up more iodine, and in toxic adenoma, decreased uptake in thyroiditis. Moving on to Graves' disease, the triad of clinical, it is also known as Besedow's disease. It is the most common cause of hyperthyroidism. Okay, so triad is hyperthyroidism with infiltrative ophthalmopathy or Graves' ophthalmopathy, and then there is infiltrative dermopathy or pretibial myxedema. So you can remember as Grave PT, so pre-T proptosis, and pretibial myxedema. Next, etiology, Graves and or Hashimoto's are considered as two extremes of autoimmune thyroid disorders. Graves is associated with hyperthyroidism, Hashimoto with hypothyroidism. So, genetic factors, Graves has a strong genetic component, again monozygotic twins, presence of antibodies in siblings, and also association with other diseases. So, CUTLA4 and PTP and 22 polymorphisms are seen. So, pathogenesis, it's an autoimmune disease. There are multiple autoantibodies. So, basically in Graves, everything is because of autoantibodies on this. So, first, there's a failure of self-tolerance, then there is autoimmunity, and that causes destruction of the thyrocytes. So, first, you have antibodies. This is the trick to remember them: TSIG, TGSIG, and TSHIG. TS, TGS, and TSH. So, first you have TSIG, which is thyroid stimulating immunoglobulin. So, what happens is these immunoglobulins, they bind to the TSH receptors and act as agonists, and they stimulate the thyroid to synthesize more thyroid hormones. Next, TGSIG, so thyroid growth stimulating immunoglobulin. So first what happens is antibodies are produced, they again bind to the receptors, and then they cause growth of the thyroid cells, so proliferation of the thyroid follicular epithelium, diffuse hyperplasia of the thyroid. Next, you have TSHIG, so TSH binding inhibitor IG, so what they can stimulate thyroid function or they can inhibit thyroid function, leading to hypothyroidism, which can coexist with hyperthyroidism. Next, infiltrative ophthalmopathy, you can see, and autoimmunity is responsible for infiltrative ophthalmopathy. So, morphology, basically, the thyroid gland is symmetrically enlarged due to diffuse hypertrophy and hyperplasia of the thyroid follicular cells. Weight of the gland is increased because of hypertrophy and hyperplasia, and again, cut section, it resembles a soft and meaty appearance. It resembles normal muscle. Okay, so muscle, you can see hypertrophy, hyperplasia, and it appears soft and meaty. So, just like that, you have Graves' disease thyroid gland. The changes in the thyroid, first you have to note that there is a crowding of epithelial cells because of the hyperplasia, because of TGSIG. So there's a crowding of epithelial cells and they form small papillae without fibrovascular cores which project into the lumen and encroach onto the colloid. The colloid is pale, which is vacuolated, you can see here, with scalloped margins, and again lymphocytic infiltration is seen in the interstitium with mature plasma cells, and commonly you can see germinal centers. Changes in the extrathyroidal tissue: because of hypermetabolic state your heart pumps more, and because of Starling's law you have myocardial hypertrophy. Next, ophthalmopathy and dermopathy. Next, thyrotoxicosis. The clinical features degree varies. The unique features are diffuse hyperplasia of the thyroid, weight of the gland increases. Ophthalmopathy, it is abnormal protrusion of the eyeball. Exophthalmos, sympathetic overactivity may produce a characteristic wide staring gaze and leg lag. So infiltrative ophthalmopathy is characterized by increase in the volume of retroorbital connective tissues and extraocular muscles. And infiltrative dermopathy or prediabeal mixed edema, it is seen in minority of patients on the skin overlying the shins. So it presents as a scaly thickening and induration of the dermis due to deposition of glycosaminoglycans or GAGs and infiltration by lymphocytes. So lab findings, you can see T3, T4 elevation, decreased TSH levels, and radioactive iodine uptake is increased, and they show a diffuse uptake of iodine. So autoantibodies triad. Graves' disease has an increased risk for other autoimmune diseases such as SLE, pernicious anemia, type 1 diabetes, and Addison's disease. And again, thyroid storm includes tachyarrhythmias, hyperpyrexia, fever, shock, and coma. Hypothyroidism is the clinical manifestations due to reduced secretion of thyroid hormones. So it is caused by reduced thyroid hormone production either due to structural or functional derangements in the thyroid. So basically, types of hypothyroidism: you have primary, which is due to intrinsic abnormality in the thyroid gland itself. So the causes are autoimmune hypothyroidism, obviously Hashimoto's, then iatrogenic if you remove the thyroid gland with surgery or any radioiodine therapy, or if you give drugs such as iodides or lithium, etc., antithyroid drugs, or if there is iodine deficiency, it is a common cause in infants and in children. And also genetic defects: there is a defect in thyroid development or dysgenesis, which is rare, and you also have congenital biosynthetic defect or hormonogenetic goiter, which is rare. And secondary hypothyroidism is due to pituitary and hypothalamic disease, so pituitary failure and hypothalamic failure. So cretinism, it is a hypothyroidism that develops in infancy or early childhood. So it formerly was fairly common in areas where there was endemic dietary iodine deficiency, such as mountainous areas like the Himalayas and the Andes. It is now less frequent because of widespread supplementation of salt with iodine, because iodized salt is available in the market now. Sporadic cretinism, it is caused due to enzyme defects that interfere with thyroid hormone synthesis in childhood. And genetic defects, rarely it may be due to genetic defects that interfere with the biosynthesis of thyroid hormone or dyshormonogenetic goiter. So clinical features: so cretinism, obviously there is mental retardation, so impaired development of the skeletal system and the CNS. It manifests as severe mental retardation, short stature, coarse facial features, a protruding tongue, and umbilical hernia. So basically, protruding tongue, protruding umbilicus or umbilical hernia, short stature, mental retardation, and coarse facial features. So nervous system, basically hypothyroidism in pregnancy produces neurological consequences. Normally the maternal T3 and T4, they cross the placenta. They are important for the development of brain in the fetus. Severity of mental impairment, it depends on the time at which fetus develops thyroid deficiency in utero. So if there is a deficiency of the thyroid hormone in the pregnant woman before the development of fetal thyroid gland, there will be severe mental retardation in the fetus. Next, mixed edema. It is hypothyroidism that develops in older children and adults. The symptoms are due to decreased circulating thyroid hormone. In older children, the signs and symptoms are intermediate between those of the cretin and those of the adult with hypothyroidism. So initial symptoms: obviously there is tiredness and mental sluggishness, which may mimic depression because it appears in adolescents, right, in young people, in older children. Next, skin. So obviously mixed edema. So cutaneous signs are the most common. The connective tissue matrix substances such as JGs and hyaluronic acid, they accumulate in the extracellular matrix in the skin and subcutaneous tissue. They bind with water and they produce a peculiar form of non-pitting edema called mixed edema. These patients have broadening and coarsening of facial features. So facial features are coarse, boggy faces, puffy eyelids, and edema of the hands and feet, enlargement of the tongue, protruding tongue, and deepening of the voice due to thickening of the laryngeal mucous membranes. The skin is cool and pale because of decreased blood flow due to cutaneous vasoconstriction. The skin is also dry, coarse, cold intolerance is seen with decreased sweating. So skin wounds, they heal slowly, and ecchymosis may develop due to capillary fragility. Nervous system, obviously they are lethargic, they mimic depression, they show memory loss and slowed mental processes. So in severe cases, mixed edema madness may develop. Other symptoms include sensory defects, cerebellar ataxia, and slow tendon reflexes. So heart, there is reduced cardiac output, which produces shortness of breath and decreased exercise capacity. And again, there are increased total cholesterol and LDL levels. And GIT, there is constipation. So lab findings in hypothyroidism: decreased serum T3, T4, increased serum TSH in primary hypothyroidism. It is the most sensitive screening test. And then it is not increased in hypothyroidism associated with the primary hypothalamic or pituitary disease. Next, hypercholesterolemia also you can do lab detection. And again, diffuse and multinodular goiter. So goiter is defined as enlargement of the thyroid without hyperthyroidism. It is the most common manifestation of thyroid disease. So the two morphological forms are diffuse non-toxic goiter and multinodular goiter. So diffuse non-toxic non-nodular colloid goiter is simple goiter. It is characterized by diffuse enlargement of the thyroid gland without any nodularity, so non-nodular. Microscopically, it consists of large thyroid follicles distended with colloid. So that is why it is also called colloid goiter. So it is of two types, endemic and sporadic. So endemic goiter is used when goiters are present in more than 10% of the population in a given region. So it is due to deficiency of iron, low iron in the soil, water and food. So it is common in mountainous areas like the Himalayas. Next, dietary supplementation of iron has reduced the frequency of endemic goiter. Consequences of iron deficiency. What happens is basically you also have goitrogens. These are substances ingestion of which interferes with the thyroid hormone synthesis. So for example, cabbage, cauliflower, Brussels sprouts and turnips, they belong to the Brassicaceae or crucifery family. They should not be eaten in patients with hypothyroidism because they interfere with thyroid hormone synthesis. And also cassava root, it contains the thiocyanate that inhibits iodide transport within the thyroid, so that also you should not eat. So deficiency of iron or goitrogens, they decrease the synthesis of thyroid hormones. So then there is a compensatory increase of serum TSH, which causes hypertrophy and hyperplasia of the thyroid follicular cells. This causes compensatory enlargement of the gland. So again, the production of thyroid hormones increases, which overcomes the deficiency, and there is a euthyroid metabolic state in most patients. It is non-toxic. Okay, it leads to diffuse non-toxic simple goiter, and when there are recurrent episodes of hyperplasia and colloid involution, then you have multinodular goiter. So that is about endemic goiter, and sporadic goiter is less frequent, and there is a female preponderance. The causes are hereditary enzyme defects that interfere with thyroid hormone synthesis. So it is transmitted as an autosomal recessive condition such as dyshormonogenetic goiter. Ingestion of substances that interfere with thyroid hormone synthesis and unknown causes. So morphology, you can see diffuse non-toxic goiter that it has two phases, so hyperplastic phase and phase of colloid involution. The colloid is moderately diffusely and symmetrically enlarged. So symmetric diffuse enlargement. Okay. Next, microscopy, you can see hyperplasia of the lining epithelium because again you have compensatory serum TSH which causes hypertrophy and hyperplasia of the lining epithelium. So the epithelium consists of crowded columnar cells which may pile up to form pseudopapillae without a fibrovascular core, and they project into the follicular lumen. And the colloid content varies throughout the gland. Some follicles are distended with colloid, whereas other follicles are have minimal colloid. So these pseudopapillae are called Sanderson's polster. Next, so the cells are becoming large. The cells are becoming more. Now there is phase of colloid involution. Subsequently, if the dietary content of iodine increases or demand for thyroid hormone increases, the hyperplastic phase goes into a phase of colloid involution. So the gland is enlarged and the cut surface is brown glassy due to colloid and translucent due to colloid. Microscopically, you can see flattened follicular epithelial lining because if the colloid increases, it flattens the lining follicles, right? And also there is abundant colloid which causes enlargement of the follicle. It is called colloid goiter. So clinical course, majority with simple goiters are clinically euthyroid and mass effects from the enlarged thyroid gland are seen. And the lab findings, serum T3, T4 are normal because it is euthyroid. Serum TSH is usually elevated or at the upper range of normal. Next, multinodular goiter. In long-standing simple goiters, recurrent episodes of hyperplasia and involution, they combine to produce a more irregular enlargement of the thyroid, known as multinodular goiter. They occur in both sporadic and endemic forms. Next, evolution of multinodular goiter. So in long-standing simple goiters, due to variations among the follicular cells in their response to external stimuli such as TSH compensatory response, what happens is multiple nodules are formed. So some cells in a follicle contain clones of proliferating cells which may become autonomous and proliferate without the external stimulus. They produce new follicles. Whereas some follicles may accumulate colloid even without epithelial proliferation. There is uneven accumulation of colloid. So there are irregular enlargements. Next, consequences. This produces physical stress on both the follicle and the surrounding blood vessels. So the rupture of the follicles may result in colloid cysts, and rupture of the vessels may produce hemorrhages followed by scarring and sometimes calcification. So with scarring, multiple nodules appear and they show varying microscopic appearance. So gross morphology, you can see multiple nodules. So it is asymmetrically enlarged and nodular, and pattern of enlargement, it varies. So one lobe of the thyroid may be more involved, one nodule may become more prominent, and the goiter may grow behind the sternum and clavicules to produce intrathoracic or plunging goiter. Next, Weight of the thyroid obviously increases. In cut section, you can see numerous irregular nodules containing variable amounts of colloid. And when the nodules contain large amounts of colloid, they appear glistening, they appear reddish brown due to gelatinous colloid, and older lesions may show areas of hemorrhage, calcification, cystic change, and fibrosis. So microscopy, obviously you can see nodules which consist of follicles of varying sizes distended with colloid and lined by flat epithelium, inactive epithelium. Colloid cysts can be seen because of rupture of the colloid containing large follicles, and you can also see follicular hyperplasia. So they produce pseudopapillae that project into the follicular lumen. They may either contain minimal or no colloid, and they may be mistaken for follicular adenoma. So no prominent capsule is seen, but in follicular adenoma, capsule is seen. Next, stroma. So there is fibrosis and dystrophic calcification, and there are areas of hemorrhage and chronic inflammation which are common. So presence of hemosiderin deposits and cholesterol granulomas indicate old hemorrhage. So clinical course, it is usually asymptomatic and presents as a mass in the neck. So large multinodular goiter may cause compression of the surrounding structure. So airway obstruction causes compression of trachea, so dysphagia. Venous congestion of the head and face, it causes superior vena cava syndrome. Hoarseness because of recurrent laryngeal nerve compression. Functional status, most patients are euthyroid. Some may have subclinical hyperthyroidism with reduced TSH levels, and some may develop plumber syndrome because the toxic multinodular goiter causes hyperthyroidism, plumber syndrome. So FNAC is useful for diagnosis. Moving on to neoplasms of the thyroid, tumors of the thyroid are usually benign. So most likely, it is likely to be neoplastic when there are solitary nodules instead of multiple ones. Nodules are there in younger patients, especially males, and also if there is a history of radiation treatment to the head and neck. So follicular adenomas of the thyroid, they consist of follicular epithelium. So pathogenesis, you have non-functional and functional. Majority of the adenomas, they do not produce thyroid hormones and are hence non-functional. So genetic factors, obviously, see follicular, right? So AR, reverse it, you get RA, so RAS. So mutations of RAS are common, and also PI3K CA mutations, and also PAX8 PAPARG fusion gene. So all these are genetic alterations also seen in follicular carcinomas. And functional follicular adenoma, they produce thyroid hormones, they're toxic adenomas, and they cause thyrotoxicosis. So somatic mutations of the TSH receptor signaling pathway have been found. So RAS PI3K signaling pathway especially, increase in that pathway. So morphology, so follicular adenoma, you have SS, 4 S's, okay. So single, spherical, solid, and soft. So it is solitary, spherical, solid, and encapsulated tumor. Size, it ranges from 1 to 3 centimeters in diameter. So cut surface, it is soft and pale compared to the surrounding gland. So it is spherical, soft, and pale. When it is fresh, the cut surface, it bulges. Okay, it has a well demarcated fibrous capsule. There is a thin intact fibrous capsule. It compresses the adjacent thyroid gland. The cut surface of the tumor bulges when fresh, and the color may range from grey white to red brown. Secondary changes may be there, so hemorrhage, fibrosis, calcification, and cystic change. So microscopy, they may show many histological patterns without any significance. So in some follicles, they may resemble the normal thyroid tissue or mimic different stages in the embryonic development of the thyroid. So you have embryonal or trabecular adenoma. So there is a trabecular pattern of follicular cells with little or no colloid. Okay, like this in trabecular pattern. Next, fetal microfollicular adenoma. So tumor cells, they are arranged in microfollicles with little colloid. Simple adenoma, mature follicles with a normal amount of colloid. Or colloid adenoma, macrofollicular adenoma. So follicles are larger and they contain more abundant colloid. And Hurtle cell adenoma, it is composed of oxyphil cells, small follicles, and scanty colloid. Atypical adenoma, so there are more mitoses, excessive cellularity, nuclear atypia, etc. So clinical features, they mostly present as a unilateral painless mass, and larger tumors may produce local symptoms. So investigations, you have radionucleotide scanning. So non-functioning adenomas, they take up less radioactive iodine, they form cold nodules, and functioning follicular adenomas, they appear as hot nodules, and malignancy is rare. So ultrasonography or USG and FNAC you can do, and again you can also do histological examination. Moving on to carcinomas. So carcinomas are relatively uncommon. So childhood and late adult life, males and females are equally affected, whereas early and middle adult life, middle and early, you have female predominance. So mostly they are well differentiated. So major subtypes, you have 4 types. So papillary, follicular, anaplastic, and medullary. So papillary is the most common. Next is follicular carcinoma. So pathogenesis, remember, origin is FAP. So follicular, anaplastic, and papillary, they are follicular cell derived malignancies. Non-follicular cancer, you have one type, that is medullary carcinoma. Next, Genetic factors. So follicular cell-derived malignancies, they result from gain-of-function mutations along components of the two signaling pathways in the thyroid gland, namely the MAP kinase pathway and the Pi3K-AKT signaling pathway. So first let us discuss the picture in detail. So first you have growth factor receptors, okay, to which the growth factors bind. There is a tyrosine kinase receptor which results in autophosphorylation of the residues, and then the downstream pathway signals are activated. So the growth factor receptors, you have stuff that promotes it, so RET and NTRK1, okay. So RET is not normally present, but mutations cause it to fuse with another gene, due to which RET is constitutively actively expressed in the thyroid cells, and it leads to MAP kinase pathway increased signaling. So then you have RAS activation, and then from there on there are two pathways. So Pi3K-AKT signaling pathway, which leads to gene transcription and cell proliferation, or BRAFORK, okay, you can remember it as bro fork. So pierce the thyroid gland with fork from your brother, so bro fork. So BRAF and ERK, MAP kinase or MK, okay, these are the two pathways. So normally these two signaling pathways are transiently activated by binding of soluble growth factor ligands to the extracellular domain of the tyrosine kinase receptors. This binding leads to autophosphorylation of the cytoplasmic domain and results in intracellular signal transduction. So mutation leads to oncogenic constitutive activation even in the absence of the ligand and promotes carcinogenesis. So first, papillary MAP kinase pathway. So PAP-MAP. So that is a mutation. MAP kinase pathway activation is a major feature of most papillary carcinomas, and it can occur by two major mechanisms. One is activation of the growth factor receptor. It is the first method. So two genes encode the transmembrane tyrosine kinase receptors, namely RET and NTRK1. RET is not normally expressed in thyroid follicular cells, but in papillary cancers, somatic rearrangements of RET gene are common. They cause it to fuse with the tyrosine kinase domain to another gene such as RET PTC. And this fusion protein causes constitutive activation of the tyrosine kinase receptor in thyroid cells, and it leads to activation of the MAP kinase pathway. Next, NTRK1. What it does is its fusion with another gene causes resultant fusion proteins and constitutive expression of that in the thyroid cells, leads to activation of MAP kinase. Next, you also have mutations in the signal transduction genes. Okay, you have signal transduction genes here, especially BRAF. So activating point mutations in BRAF, whose product is an intermediate signaling pathway in the MAP kinase protein in the MAP kinase pathway. So that causes increased signaling. So point mutations, it is observed in 30% of cancers, and it is associated with metastatic disease and extrathyroidal extension. So RET PTC rearrangements and BRAF point mutations are not found in follicular adenomas or carcinomas, only in papillary carcinomas, PAP-MAP. Next, follicular carcinomas. There are mutations in this pathway, so that is a Pi3K-AKT signaling pathway. So basically, you have tumors with gain of function point mutations of RAS. Okay, so first there are mutations here. The next, PTEN tumor suppressor gene. So mutated PTEN, again it causes activation of the downstream AKT, and again PAX8 PAPARG fusion gene. So this fusion gene also, it kind of increases both RAS signaling and Pi3K-AKT signaling. Then you have anaplastic carcinomas. They are highly aggressive and lethal tumors. They can arise de novo or by de-differentiation of a well-differentiated already papillary or follicular carcinoma. Other genetic changes, you can have P53 inactivation or mutations of beta-catenin. And again, non-follicular cell-derived malignancies, you can remember it as medullary thyroid carcinoma, medulla RET. So you have RET mutations. It is common in MEN2 and germline RET gene mutations. The RET codes for receptor tyrosine kinase, and oncogenic version of RET leads to constitutive activation of the tyrosine kinase receptor and cell proliferation. Next, you also have environmental factors such as ionizing radiations and deficiency of dietary iodine. So papillary thyroid carcinoma, you can remember it as papillary. So papamama, so some of bodies are seen. So papam you say for orphans, so orphan ani and nuclei are seen with intranuclear grooves, and papillary architecture obviously. So it is the most common and constitutes 85% of primary thyroid cancer. It can occur at any age, but approximately 25 to 50 years. 25 to 50 years, you start getting grey white hair. So color is grey white, okay. So again, it is associated with previous exposure to ionizing radiation. So growth, it can be solitary or multifocal. It is well circumscribed, or it can be encapsulated, or it can be ill-defined. So grey white firm to hard tumor is seen. Okay, you can see here multiple papillae, grey white firm to hard. In microscopy, you can see complex branching papillae. Cut surface, you can see papillary foci. So these branching papillae, they have a dense fibrovascular stalk or core. They are covered by single to multiple layers of uniform cuboidal to columnar epithelial cells. Okay, these papillae, they are covered by uniform cuboidal to columnar epithelial cells, and the nuclear features, they are very important for the diagnosis even in the absence of papillary architecture. So you can see ground glass or orphan ani nuclei. They have finely dispersed chromatin, which gives an optically clear appearance. Okay. and empty appearance, and intranuclear inclusions and intranuclear grooves are seen because invaginations of the cytoplasm into the nucleus in cross sections may give the appearance of eosinophilic nuclear inclusions, pseudo inclusions, or intranuclear grooves. Next, you can see calcospheroids or psammoma bodies are concentrically calcified structures usually present within the papillary core, as you can see here. Next, they are virtually diagnostic of papillary carcinoma, but they are never found in follicular and medullary carcinomas. Next, lymphatic spread. So lymphatic invasion and spread to regional lymph nodes is common, but vascular invasion and blood spread is uncommon. So usually papillary, so lymphatic spread. Next, you have histological variants. So follicular variant is the most common variant, and the nucleus show characteristic features of papillary carcinoma but with follicular architecture. Next, you have tall and columnar cell variants. You have diffuse sclerosing variants. So there is extensive diffuse fibrosis and prominent lymphocytic infiltrates in papillary microcarcinoma. It's an incidental finding on surgery. So clinical course, most papillary carcinomas, they present as asymptomatic thyroid nodules, and FNAC you can do, and prognosis is excellent. Next, follicular thyroid carcinomas, they are more common in women. They develop at an older age than papillary carcinoma with peak incidence between 40 to 60 years of life. They are more frequent in regions where there is iodine deficiency. Next, so morphology, papillary carcinoma is grey white. Here it is grey pink. So it is single nodules which may either be well circumscribed or infiltrate into the surrounding thyroid parenchyma. So the cut section is grey to pink. Microscopy, you can see a follicular pattern, as the name indicates, of tumor cells. So they consist of uniform cuboidal to columnar follicular epithelial cells. The tumor cells may form small follicles containing colloid or may be arranged in sheets or nests without forming follicles. There is increased mitotic activity. So invasion can be divided into three variants based on the pattern of invasion for cancer. So there is minimally invasive follicular carcinoma. It is well defined and encapsulated, but it shows mitosis and capsular invasion even though it resembles follicular adenoma. Next, it can be encapsulated but angioinvasive, vascular invasion, and then widely invasive. They infiltrate the thyroid parenchyma, the capsule, and also the extra thyroidal soft tissue surrounding it. So metastasis, there is lymphatic spread, which is uncommon, but hematogenous spread is more common, as opposed to papillary carcinoma where lymphatic spread was more common. So follicular carcinoma, they present as slowly enlarging painless nodules. Next, anaplastic or undifferentiated thyroid carcinoma, they are undifferentiated tumors of follicular epithelium. They are present in elderly people. So usually they are diffuse infiltrative tumors, and microscopically you can see spindle cells, you can see large pleomorphic giant cells, and mixed spindle and giant cells. So giant cells, because they appear in giant people or elderly people. Next, immunohistochemistry, they express epithelial markers like cytokeratin but are usually negative for thyroglobulin. So spread, they have local spread into thyroid capsule and hematogen spread into the lungs. So clinical course, they present as a rapidly growing bulky neck mass. Symptoms due to compression and invasion of the neck structures may be seen. They have a poor prognosis. Next, medullary thyroid carcinoma. So it is a neuroendocrine tumor derived from parafollicular cells or C cells of the thyroid. So they secrete calcitonin, measurement of which is useful in the diagnosis and post-op follow-up. And again, types, you have sporadic types and familial types. So familial are associated with Men syndrome 2A or 2B or without an associated Men syndrome. You also have medulla ret, right? So point mutations in the ret gene. Next, morphology. So obviously medulla ret, right? Remember as medulla red. So areas of necrosis and hemorrhage are seen, larger lesions. Tumor is firm and pale grey here, again grey, and solitary nodule in sporadic and multicentric in familial cases. Next, microscopy, you can see polygonal to spindle shaped cells here, and again the cells are arranged as nests or in trabeculae, etc. And also acellular amyloid deposits in the stroma can be seen. They are derived from altered calcitonin polypeptides. And again you can see C-cell hyperplasia. It is seen in the surrounding thyroid of familial medullary cancers, which is not observed in sporadic lesions. So in familial cancers you can see C-cell hyperplasia. They represent the precursor lesions. Immunohistochemistry, obviously you can demonstrate calcitonin within the stromal amyloid and cytoplasm. Electron microscopy, you can see membrane bound electron dense granules within the cytoplasm of the tumor cells. So clinical course, in sporadic cases it presents as a mass in the neck, and you can also see a paraneoplastic syndrome which may occur in some medullary carcinomas. And also tumor markers, you have calcitonin and carcinoembryonic antigen or CA. So familial cases, they present with symptoms localized to the thyroid and meant to be so medullary carcinomas arising as meant to be components are more aggressive and they frequently metastasize.